My name is Suzanne Li. I'm a pediatric rheumatologist at the Joseph M. Sansari's Children's Hospital in Hackensack, New Jersey. And I'd like to thank the Scleroderma Foundation for sponsoring this wonderful conference. And this is pretty informal, so I welcome, people asking questions and stuff. So, sorry, I didn't. My talk is Common Complications in Juvenile Localized Scleroderma and General Health Guidelines. And as Dr. Vasquez Canizari said, we don't have much time, so it's we're just touching on these things. So again, questions are welcome. So I'm going to be talking about extracutaneous involvement, which Dr. Vasquez Canizari said. So this is, I'm going to be touching on joints, muscle, bone, and growth, as well as eye neurological problems, so nerves and brain, and oral dental issues. And then management strategies, so the 504 plan and healthy lifestyle, which is really important for lowering your inflammatory state. So extracutaneous involvement, as Dr. Vasquez Canizari said, is quite common, so about 50%. And it's associated with all those subtypes that were shown. And it's the primary cause of moderate and severe problems in children with localized scleroderma. Most, but not all of these extracutaneous involvement occur after the onset of skin lesions. About a quarter of joint problems start before, and about a sixth of neurological problems start before. So as Dr. Vasquez said, evaluation by a pediatric rheumatologist is really important because you really want a full body evaluation. So this pie chart is showing you the breakdown of the different types of extracutaneous involvement. And so musculoskeletal, which means joints, bone, or muscle, is the most common type, over half. And this is going to be more common with the linear scleroderma. And then the neurological eye oral problems are more common with the sorry, I don't know why it's not sort of clicking. Okay, this is more common with the linear, and then the neural eye oral is more common with the craniofacial involvement, also linear scleroderma. So as was mentioned before, lung, heart, kidney, gut involvement can occur, but these are typically mild or asymptomatic, so very different than systemic sclerosis, where this involvement tends to be progressive and severe. Here we might have some problems with swallowing or reflux, but again, it tends to be pretty mild or asymptomatic. Vascular problems include things like certain types of rashes, cold hands, or Raynaud's, but the Raynaud's tends to be much better than systemic, as it isn't progressive. So in terms of musculoskeletal, joints occur in over a third of the patients. And this could be joint limitations or contractures, like we see here, where this child can't fully make a fist. And this could be because there is an effect on the skin, that hardening of the skin, or it could be that the underlying tissue, the deep tissues like the muscle, the tendons are also affected by that fibrosis, so that you can't bend it fully. Arthritis can look just like typical inflammatory arthritis, like we see with juvenile idiopathic arthritis, rheumatoid arthritis, where we have swelling of the joints, like here the wrist and all of these fingers. And important thing to note is that for 80% of the children, this arthritis can be removed from the skin disease. So in this child, there is skin disease affecting the first, second, and third finger, but the fourth and fifth finger are equally affected by arthritis. And this kind of polyarticular, meaning 5 or more joints, is the common pattern, and both small joints and large joints can be affected. So these children can act just like a child with juvenile arthritis, and they might be diagnosed that way first, with having morning stiffness or pain, some limitation in activity. And this is an MRIs showing you what this kind of arthritis can look like. So in the top picture, this is the typical pattern for inflammatory arthritis. So a dye was given, gadolinium, which will light up at sites of inflammation. So we see this kind of brightness around some of the bones of the wrist here. And you see that some of the spaces between the bones is a little bit larger, and that's because there's swelling from effusion, as well as the joint lining is a little bit thickened by that inflammation. In the bottom, we really don't see that much brightness. There's a little bit here, here, here. So this is this fibrous arthropathy, which is very common in the localized scleroderma. So again, the spaces between the bones is larger. So there is extra tissue and there is some inflammation, but there is also, unfortunately, that fibrosis going on here. So we treat these the same as we would treat for other types of inflammatory arthritis because there is inflammation. So we're going to use immunosuppressants like we do for juvenile idiopathic arthritis, so methotrexate, as Dr. Vasquez mentioned, and they can respond very well to that, but some patients may need other medications to get this under control. Physical activity is very important, so occupational therapy, physical therapy as needed, but also you want your child to keep using that affected site. So it's really important to stretch for them to keep working to try to restore that function, because you should think of this as really being like scar tissue. So once we get that inflammation under control, you have to try to break up that scar tissue to get the full movement restored. Another common musculoskeletal problem is muscle involvement, which also affects over a third of the children. And this could be atrophy, which means that the muscle is smaller, which could be from overlying tight skin, so the muscle can't grow so well. Or it could be from the bone didn't grow so well, and the bone and muscle are like a unit, so the growth is regulated by each other. Or there could be inflammation. That inflammation we call myositis, and this can also occur remote from the skin lesion in about a quarter of the cases. And the child could have problems like weakness, cramping, as well as atrophy. And this we're going to diagnose often by MRI. Blood tests can help, but that inflammation is often very limited, so may not show up in the blood. These children can also have muscle spasms, dystonia, or pain, and this could represent a nerve problem, peripheral neuropathy, or it could represent a primary muscle problem. So this is an MRI of muscles of the leg. So this is the unaffected leg, and this is the affected leg. So you could see that this white surrounding tissue is thinner in many places compared to the unaffected leg, and this is the mostly fat here, as well as the overlying skin. And then the muscles are also smaller on the affected side, so that's that atrophy. The bone is also smaller, so some of this atrophy is probably related to that undergrowth of the bone. So imaging is very helpful for evaluating for inflammation as well as labs. And in this patient, we don't see any extra brightness, so there isn't any inflammation going on. If there is inflammation, we often are treating with steroids, corticosteroids, because that's very effective at controlling the inflammation. And then we also want to use methotrexate and other disease-modifying anti-rheumatic drugs, DMARDs. If the child is having pain or spasm, you want to consider other treatments. And so you really want to partner with neurology and often pain management. And medicines like Botox or antispasmodics might be used. And the pain management may be suggesting medicines beside acetaminophen and ibuprofen to help with management. Again, it's really important to focus on recovery. So physical therapy, occupational therapy, physical activity. And so we want to encourage regular play and exercise to help preserve muscle as well as to build it up. And then growth is a really important issue for our children. Growth impairment is common, a quarter or more. And this growth impairment could be of many tissues. So we have bone and muscle, but also soft tissues like the fat, breast, buttock. And the severity level, fortunately, has decreased with methotrexate treatment. So as Dr. Vasquez said, you know, this treatment has been very effective. So we're seeing fewer surgeries, a lower level of impairment. And you want to monitor that because worsening body asymmetry could be a sign of activity. And so this is a picture of a young boy who has a linear lesion of his face, and it's affected the right side of his nose, which is narrower. There is some flattening of his forehead here, okay? And then over time, the nose became even narrower. There's some deviation of his face to the left. There's more flattening of his cheek now, as well as his forehead. So potentially, if we identify the growth impairment earlier, we may be able to intervene earlier and decrease that severity risk, because kids do have a great capacity to grow. So if we get it under control, we may be able to help them regain some of that growth impairment. And so for patients that have craniofacial disease, eye problems occur in up to a third of the patients with linear. So in this boy that has a linear lesion of his forehead here, we can get involvement of any part of the eye or surrounding tissue. So there's a decrease in his eyebrow, but also his eyelashes here. And then because the lesion is going medially, it could affect the tear duct, the lacrimal gland, so the eye can be dry. In addition, because we, as I've shown you, there can be atrophy. So there's fat behind the eye. So then the position of the eye can be recessed backwards. So that's enophthalmos. It's really important that an ophthalmologist, so that's an eye doctor, not just an optometrist, is screening the eye. So we recommend baseline screening for all patients with localized scleroderma. And then for those with craniofacial involvement or anyone who's found to have involvement, follow-up is really important too. And so that eye doctor will be dilating the pupil to look inside the eye, to look for inflammation, which is most commonly uveitis, but other structures can also be affected. And that monitoring is really important, especially as you're tapering or off medicines, because the eye may flare before the skin flares. For treatment, if there's eye inflammation, we're doing standard uveitis treatment with immunosuppressive drugs for more serious involvement. And if there's problems with the positioning, sometimes plastic or corrective surgery will be done. In terms of neurological problems, this, similar to eye problems, is not correlated with skin activity. Most present after onset of skin disease, with over a quarter presenting within the first year after skin lesions, but the median time to presentation is about 4 years later. We are going to want to do a baseline MRI of the brain in all of our patients, and so we're looking most commonly for white matter changes. So this patient has died, but there are areas like here and here and here that have extra white matter signal. Okay, and so if we do find that there is changes in the brain MRI, typically we're going to do follow-up. But keep in mind that there is so far only limited correlation found between the MRI images and clinical features. So somebody could have MRI changes and have no clinical findings. But the presence of them, of course, is going to make us worry that there could be development of some problems. Headaches and seizures are the most common neurological problems, and the headaches can be more typical headaches, or they could be migraine and quite severe. Seizures can be many different forms, partial, generalized, absent seizures. Other problems are neuropathy or palsy, and this could be in the face or peripherally. And treatment, similar to the others, is with immunosuppressive drugs, which is found to be helpful for many of these patients. But we want to partner with neurology to help us manage these patients. And if the patient has seizures, we want to use anti-epileptics, so other medicines may also be needed. Oral and dental problems are also going to be more common in patients with craniofacial involvement. And those that have earlier onset, meaning under age 6, are at increased risk for growth problems. So in this patient, there is a tooth missing here, okay? And so you really want the dentist to be helping monitoring these patients. So x-rays to look for any kind of root problem. You want to look for malalignment, and that's also going to be of the jaw. And so there can be muscle spasms. So in this patient, the right masseter muscle is larger because it's hypertrophied from repeated spasms on the affected side of his face. And for treatment, then spasms could be treated with Botox, and sometimes, reconstructive surgery is needed, or implants are needed, grafts to help correct. So a key tool for management is the 504 plan. So this is really an important tool to help you with managing school and medical care. And so this is a congressional law that requires the needs of students with disabilities, or it's defined more broadly as limitations or handicap, be met adequately. And it's going to apply to schools that receive federal funding, so public schools, not necessarily private. And so limitations or handicaps include medical conditions. So potential accommodations could include excusing latenesses or absences because of medical visits or treatments, assistance with note-taking if your child has problems with their hand, potentially rearranging the class schedule to help so that gym might not be the best as the first period, and extra textbooks or other aids. In terms of general health recommendations, for patients, this is a skin disease, so we do recommend skin protection, so sunblock, and then moisturizers. And patients that have that hard skin, they may be at increased risk for breakdown. So you do want to protect against potential infection, any kind of cuts in that area. You should smear some kind of antimicrobial, make sure it's clean, okay, because it may not heal as well because it is thinner. And then I strongly recommend a healthy lifestyle, because that's been associated with a decreased pro-inflammatory immune state. And as Dr. Vasquez told you, this is a problem where your immune state is too active. So we really want to have a decrease in that state. And the healthy lifestyle also improves tissue recovery. So a healthy lifestyle means a healthy weight, Mediterranean style type diet, which means lots of fruits and vegetables in your diet as opposed to red meat or other types of protein, lots of grains, good source of calcium, vitamin D for your child, healthy oils like olive oil, and physical activity, good sleep, stress management are all important. This is just a link that describes some healthy recipes. Physical activity, it has really many benefits for children. So it's been shown to improve their thinking, their learning, their sleep, their mood. It reduces the risk for depression, diabetes, some cancers. Yet only 1 in 4 children get the recommended physical activity. And that recommendation is 60 minutes per day of moderate to vigorous activity for 6 to 17-year-olds. Under 6, they should just be active throughout the day. And just to keep in mind that activity doesn't have to be continuous, meaning you don't have to do a straight 60 minutes. You could have your child play for 5 to 10 minutes outside. After school, they could ride their bike for a few minutes. Family activities, including some chores such as raking leaves, taking out the garbage, that could all count. Really encourage, the family to consider doing walks or hikes on the weekend together, nice family activity. These are some sites that give some suggestions for, how to be more physically active. Oops, what happened there? Sorry, long time. And so then sleep is another critical thing. So this is from the CDC. Do your children get enough sleep? And the bad answer is that 60 to 70% of children do not. So it's worse for high school, 7 and 10, versus middle school, 6 and 10. And what's recommended is for children 6 to 12, 9 to 12 hours of sleep, teenagers 8 to 10. And this is really essential for both your brain and your body. It helps your tissues grow and heal. Certain hormones are released while you sleep. It helps with your learning because memories are stored. Your mood is balanced. And so both the quantity, but just also the quality is very important. So if you're feeling tired in the morning, it means it was a poor quality sleep. And this is some tips for getting good sleep from the CDC. So a regular schedule is really important, and this is going to be determined by school. So meaning you shouldn't necessarily let your child sleep to noon on the weekends. That actually isn't really doing them a lot of benefit. You really want to have no electronic screens right before bed for at least a half an hour. That's too stimulating for your brain. So your brain really needs some downtime before you go to sleep. And that's going to involve things like low-tech activities, like relaxing with crafts or journaling or reading, paper book. And being active during the day is going to help with this. So this is some recommendations from the CDC also to help. And then stress management. So beside exercise, sleep, and diet, it's good to consider other strategies. So going outside, enjoying nature.
Dr. Li, we have about 1 minute left.
Okay, great.
Thank you.
Just well done. So there's something called forest bathing, which is common in Japan. They found that pine trees actually secrete something which is relaxing for people. So focusing on breath. So there's many different types of breathing strategies, and this is going to slowing down your breath will increase your parasympathetic, which tends to relax you. Limiting news on social issues. So it's been found that if teens spend too much time going over news like gun violence, climate change, discrimination, harassment, that all increases their stress. And trying to encourage talking to trusted adult members as well as journaling will help. And then there are many resources available for how to cope with stressful situations, relaxation techniques, building resilience in uncertain times. And these are like some strategies for the younger child to just try to help them, relax. So again, I really encourage you to try to reach out to try some of these things for your family. And, thank you for your attention. I'm happy to take any questions.
Great. Thank you. And definitely going to invite some verbal questions. We did have one that came in via the chat. And Laura, I don't know if you want to read your question yourself, but for the time being, I can read it. Since we know tattooing may trigger a flare, would you recommend not taking out wisdom teeth as not to trigger ECDS?
Yeah, so it's it's sort of a balancing thing. So we all want to know what causes this disease, and in maybe up to 15% of children with localized scleroderma, it's been associated with trauma. And so that trauma could include, falling on the defective side or surgery. So the wisdom teeth, if that's right where your child has active disease, maybe it's better to postpone it. But typically there isn't that much activity, I think, in the teeth or the jaw, the inner mouth area for most patients. In most patients, those findings are more a reflection of prior damage, influence. So I think generally, if it isn't felt to be so active in your mouth, I don't know that you have to delay the wisdom teeth, because again, that them being impacted will also be a stress on the mouth too. So it's like a balancing act.
No other questions in the chat, so I would invite anyone with a question to either do so verbally, or if you're more comfortable writing it, we can read that as well.
I think there was a question before for Dr. Vasquez about whether stress could, trigger this. So I think the idea is that, if your child is stressed today, they just broke up with their boyfriend or girlfriend, that's not going to cause them to have a flare next week, but it's really sort of the accumulation of stress we think could have a bad effect. So that's why just trying to develop healthy lifestyles, because this disease can flare years later. So if you try to help them develop strategy to mitigate that problem, we think that this in general will lead to healthier outcomes.
Can you hear me? I have a question.
Sure.
My daughter is transitioning to an adult, all physicians, cardiologists, rheumatologists, and find that the pediatric rheumatologist and the adult rheumatologist don't agree. Of course, we're going to get a second opinion, but is there a specific type of, are there different types of adult rheumatologists, or is it just that label, internal medicine / rheumatology, or it's kind of confusing to switch from it. Yeah.
It's definitely confusing. And I think that this is a big problem that Dr. Vasquez sort of alluded to, that the adult rheumatologists are often more familiar with a different form of the localized scleroderma, which tends to be milder. So they may have less experience with the the childhood form of localized scleroderma, which tends to be more severe and has poor outcome. I think that the Scleroderma Foundation lists, doctors with scleroderma expertise. So they, I think, will, potentially be better than the average adult rheumatologist, though they tend to be more focused on systemic sclerosis. I think they are going to be familiar with the scleroderma pathophysiology, which is similar to, what's going on in localized scleroderma. So that might be a consideration also.
Okay, I'll do that. Thank you.
There are also rheumatologists that we call med-peds rheumatologists that are trained in treating both adult and pediatrics.
Oh, okay.
There's not a lot of those providers, but, that can be helpful because they've trained to, identify problems in kids and adults.
Okay, yeah, similar to, well, yeah. Okay, thank you.
Yeah, I would agree. I think if you could find a med-peds rheumatologist, that would be the best because they often are spending quite a bit of time with pediatric rheumatologists, so they really know where we're coming from.
Right, thank you.
A few questions came in from the chat. One, do you think a child with linear scleroderma should be followed by a pediatric rheumatologist and an adult rheumatologist? I think if you want to clarify that question, please do so.
Yeah, I think that ideally your child as an adult is going to be followed by an adult rheumatologist who's experienced because, as pediatric rheumatologists, I'm seeing some children in their, or I guess they're not children, but I refer to my children as children still, in their 20s or even, potentially 30s. But the idea is that as a pediatric rheumatologist, I do not have hospital privileges for patients above age 22. So not that your child's likely to end up in the hospital, but in case they do, I cannot help coordinate your child's care. So it's really better for adults, but I think that there's been this problem of not enough awareness. So that's something that, we've been working in the pediatric rheumatology localized scleroderma groups to try to raise awareness among adult rheumatologists and to try to develop resources to help them understand better what are the issues, because I think that a number of patients just get shunted to adult dermatology, and I don't think that's really optimal care for these patients.
All right, I know we're trying to make up some more time, so can I ask for one more question here and then launch into the second presentation, if that's okay? So I think there was someone that was trying to speak. I'm sorry to cut you off.
Oh yeah, no, that was me. I was going to ask another question. I guess it's more protocol. The one rheumatologist, he basically thinks it's one thing, right? But then I asked him about some, other stuff going on her skin that I believe is, related. The muscle loss, right? And he says, well, I don't know. So that's why I'm also seeking a second opinion. And he said if the other doctor, because I'm in one town in Texas, I'm going to Houston, and he says if that doctor actually makes a diagnosis, he can no longer treat my daughter. And I thought if you don't know what's wrong with her, and this other doctor I'm getting a second opinion says this is what it is in my hometown, shouldn't he treat her?
Yeah, I think that, generally it's good to be humble in medicine. There's so much our patients teach us all the time. So I don't think, I would say that any of us know everything. That doctor doesn't sound like they have the best attitude for going forward. So
okay,
it may not be the best.
That's what I thought. Okay, thank you.
Okay, thank you.